Dr. Kim, what is the rate of cleft palates and palate deformities among births in Malaysia?
Historically, it's been quoted as 1 in 600 live births in the population. So for our population in Malaysia, we estimated there will be about 1,000 new cases per year in this country.
Gosh, that's a volume.
Yes. But put into context, for example, in China and in India, because of their increased population, they are dealing in terms of like 30,000, 40,000 a year.
Wow.
All right, so it's proportional to the population of a country. So in our country, we are estimating about 1,000 new cases a year.
Okay. Are there different types of cleft lips and palate deformities in Malaysia? What's the most common one that we see generally, if there is such a thing?
Because of the way that the face is formed, because the tissue has to roll to the front and then join up in the middle on both sides. I mean, because of the way this is formed, you don't need too many variations of the lip and palate deformity. But the most common one is the unilateral complete cleft lip and palate, which means that there's a cleft from the lip, nose, the gum, hard palate, and soft palate, all the way through. That's the most common deformity.
How would you explain what a cleft is to a layperson like myself in terms of trying to understand this a little bit better?
Okay. Now, when the baby is first developing at about 10 weeks, the face is flat. So it has to grow and then migrate and come around to the middle to midline.
Wow, okay.
But the line of fusion, we have line of fusion in our face. So the line of fusion for this part of the face is in the piltron column, which means the two sides on either side of the lip. Yeah. So, and then the gum is also similar on both sides of the front, and then it goes right around to the midline to the back of the soft palate. So whenever there is a problem in the migration and fusion of the skin and muscle and bone, then you get a cleft. It doesn't join up.
Right.
So it's a lack of fusion, a failure of fusion of normal skin and bone and muscle in a face. So this can happen anywhere along the face, but the most common one is the lip and palate deformity.
Okay. So what other craniofacial deformities are babies born with then?
Or you can go through the eye, you can go to the lower jaw, you can go through the brain, it can go to all sorts of different lines of fusion in the body. But those are quite rare ones. So those are the craniofacial ones that are quite rare.
And how early can you tell? I mean, possibly not during in an ultrasound, but can you tell while the baby
in vitro?
is? Yeah.
Yeah, you can tell with good modern ultrasound, very high-tech ultrasound. You can pick these up very early on in pregnancy.
And can anything be done even at that point, or at the moment are studies being done to do that?
No, you can't operate in utero. It's far too small and far too dangerous. And people have tried to do that in the past with great mortality, so it's not recommended.
Right.
Okay. Is there any specific factor that contributes to cleft lips and palates in general?
We certainly know that the most common one is there's a genetic variation in the inheritance of this. So in about a third of cases, there is actually a genetic history. So it can run in families from generation to generation. So there's 1/3 of it.
Right.
Another third of patients we know is related to one specific medication, which is an epileptic drug called epinephrine.
Right.
So for epileptic mothers who take this medicine, there's a high risk of getting this cleft deformity.
Right.
All other drugs are pertinent to normal congenital anomalies like folic acid and that kind of thing. I mean, that's related to all deformities generally, not just specific to cleft and palate only. And about a third of cases, there's really no specific history why it happened. So we don't really know in a lot of these cases.
So it's not about parents who smoke and drink or whatever. None of those actually cause it.
No evidence to suggest that causes a congenital anomaly.
Okay.
It's Clef anyway.
So at what age should parents take their babies to see a consultant to start off the journey, if they can, of corrective surgery?
I think you need to see the baby early on, after the baby is first born, first of all, to diagnose the deformity.
Mm-hmm.
Then, when you have a full diagnosis, then you can have a formulated plan of action. What to do then? It's then you can counsel a patient and prepare the patient for future treatment. So I like to see the patient very early on, if I can.
Mm-hmm.
Usually after birth rate. That will give you, the most important thing is to make the diagnosis after birth to decide what sort of long-term plan you need for the baby.
And how young can surgery be done on a child?
Generally, we like to do them at about 3 months of age.
Oh, wow. Okay, that's really young.
Yeah, 3 months. After 3 months, if they're good age, good size, good weight, healthy, and then we can start the procedure.
What's a good size though?
Size is really, we cannot obviously quantify size. We can quantify weight to give us an idea of the size of the baby. Generally speaking, over 6 kilos, 7 kilos would be a good size for a baby.
And don't forget, JD, like some babies from different parts of the world, they may weigh the same, but they're actually sort of skinny because they're longer.
Yeah.
You know what I mean?
Right. Actually, are there differences? I mean, like Western babies and Asian babies, because it's a different.
Generally speaking, Asian babies are smaller than Western babies.
Right.
Some of them, I mean, generally, we are much smaller in stature anyway.
Yeah.
Compared to the Western.
I'm just thinking.
Perfectly formed, doctor. Yeah. Perfectly formed.
If that's a child, the earlier you do surgery on the child to repair, in a way, the cleft palate or cleft lip, does it mean that as he or she grows, that means there's less scarring? Is it better to wait for them to be older? How does that work?
The basic principle of doing surgery in babies is one, you want to get it done before they learn how to speak. Well, obviously in the cleft palate. So it's important. Get the palate done before speech occurs. The other factor to think about is you want to get all the operation done early on so that the child doesn't have memory of this. Right? So they don't remember that they've had surgery in infancy. Right. So try to get it done before 1 year, 18 months of age to have the advantage of the child not remembering later on. Scarring, to a certain extent, if you do early, will lead to better scarring, but scarring generally will improve with time anyway. If the surgery is done correctly and well, and then scarring generally will improve in time. So the child will have, there's plenty of time for the scar to mature and fade away in the future. So that's not a real issue.
So should a parent decide not to do the surgery or can't do the surgery, what would the quality of life be for that child? What would it look like?
I remember looking after a patient in Sarawak when I went over there to do some cases. I met up with a 55-year-old man who never had any surgery done. You know, lips and palate completely untouched.
Right.
And when you ask him what his life has been like, it is a really, really sorry tale to tell. I mean, she said didn't go to school. He couldn't go to school because he couldn't speak.
Right.
He was teased at school, so he dropped out of school early. When you drop out of school early, you can't get a job. When you don't have a job, you don't have any income. When you don't have any income, you can't get a family, you can't get married. So this child, is like an outcast where he's living in a village in Sarawak. So that is the consequence of not having the surgery done. If he had his operation done at the right time, his life would have been so much different. Being able to fulfill all the potential that all of us have.
Yeah. You mentioned the difficulty with sort of speaking. What other problems arise with having a cleft lip or cleft palate that people might not actually realize?
Okay, so if the deformity affects the lip, you get an appearance issue. If the deformity affects the gum, you'll have a dental issue. If the deformity affects the palate, then you have a speech issue. And that's related to hearing issues because of hearing and speech related.
Right.
So all of that is affected. Then you'll have a problem with the growth of the skeleton of our skull because the upper part of the jaw does not grow as well as the lower jaw. So your mid-face gets collapsed in. So that's appearance issue. I mean, if nothing's done, then obviously the psychological issue will come into it.
Yeah.
Because when it's very difficult to go to school or be part of your community if you look different.
Absolutely.
So that's why it's so important to get all these children done early on at the right time.
Do they have nutritional issues? I mean, like, can they eat as well as other, I hate to use the word, but regular kids, I suppose?
Typical.
Typical,
Yes.
yeah.
Yes. Initially, when a baby is first born, they have some issues with feeding because obviously if there's a cleft in the palate, then you have milk leaking out the nose, that kind of thing. So you need some special bottles, special equipment to help the baby feed. But most babies eventually will learn to feed with different kind of bottles available. And generally speaking, the other issue is that if the child has lost a lot of teeth in infancy or early childhood, and then they have issues with growth because they cannot eat, they have no teeth. So we've got to look after their teeth early on so that they can have normal dentition, so that it will not affect their appetite and food. But generally speaking, they have normal teeth, they have no issues with eating.
Okay. So from what you've been saying, and sort of the number of children born with a cleft lip or palate, it seems to me like surgery isn't readily accessible or available to all of them. So how much does a surgery or how much do surgeries, because it's not just one, is it, cost for a family who with a child who has a cleft lip or palate?
Before we go into the costing, we've got to tell you about the protocol that the child has to go through and the number of procedures you have to go through before we go to that.
Right.
So initially, we have to do the repair of the lip and palate in infancy. So get it done in the first year of life. And after that, you have to look at the speech assessment when the speech is learned at about 3 years of age. If there's a problem, then they need a bit of therapy with speech. Looking after the teeth is very important at this age. Avoiding sugar in a diet is very important. Avoiding a very popular drink in this country is very important.
Yes.
Getting rid of the bottle at night is very important. So those are the things that the parents must do to look after the teeth, because the child will need dental treatment as they grow older. So the next port of call is at about 5 years old, when the child's just about ready to go to primary school. Check the lip, check the nose. If they need to be revised, do it then. If the speech is affected, sometimes the palate needs to be re-repaired, do it at about 5 years old before they go to primary school. The key is to get them looking good and speaking well when they start school, so they look normal. Then the next important phase of the treatment is at 8 years old, when the permanent teeth have come through. They need a period of time of dental treatment with an orthodontist. Now, this is to line the teeth up all in right position, so that they can prepare. They can be prepared for an operation, very important operation, to bridge that gum that's cleft with bone. That's called alveolar bone graft. Alveolus is the medical term for gum.
Right.
So we need to take some bone from the hip and put it inside the gum to bridge it, so that the 2 pieces of gum or 3 pieces of gum become one complete, one piece. So that takes you up to about 9 to 10 years old to do that operation.
Yeah.
And after that, a bit more orthodontics to line the teeth up. So the next stage of treatment will be when they're fully grown at about 16 to 18 years old. Now that's a time you take stock again, and looking at the lip, looking at the nose, looking at the teeth, the speech. And in certain percentage of patients, they will need to have the jaw moved because the jaw is collapsed in.
Right.
So that's a major operation when they're young adults. So the key, again, then, is to get it done when the child is fully grown and still under your care. So, because once they leave home and go to university and work, it's very difficult for them to have any more treatment. So it's important that all these treatments completed at about 18 before they go to university, before they go off to work.
Why do you say it's difficult for them to have it done when they leave? Is it because of
the time it takes to do all this treatment? Right. Because they need to take time off.
Right.
Orthodontics takes like about 3 years. Bone grafting takes another week, 10 days to heal, and takes 3 months. You know, you need that time to prepare and to recover and to get it right. So once you leave home and in university, you're far too busy to do all this kind of thing. You know, you want to get all done early before they leave home.
So it sounds like you've got to invest in a good 20 years or 16, 17 years to actually ensure that your child has all that he or she needs.
That's right. Yeah. This is a long-term plan. This is a long haul. It's not a short-term one-off operation.
And just think about
that's why when it comes down to cost, it's very important that they understand that this is the what it is. Now, in Malaysia, we have, as you know, there are 2 systems: private and public. Yeah. All these operations are available in a public sector. But in the public sector, the problem is that they're inundated with it. The wait list is very long. And so sometimes the kids don't get done because of the length of waiting that they have to do. So sometimes they want to come and do it in the private sector. In the private sector, we have spare capacity. We're able to take these cases on, but the problem is the financing of it. Right. Yeah. average cost for an operation in the public sector, in a private sector, is about 8,000 to 9,000 ringgit. And one of the things that parents have difficulty in is how to finance this, because they have to get a payout of cash because they're unable to buy insurance for this.
Oh, you can't get insurance for this?
No, unfortunately, because one of the exclusion for buying insurance for the kid is it's a congenital condition. It is a congenital condition that exclude a lot of kids from buying insurance.
Gosh, so basically parents are left with that awful situation of putting their kids through a marathon and an extremely painful process, physically and mentally, either, you know, waiting in the government sector, in which case they may not even get seen to, or having to go private, but then having to figure out how they pay actually for both of those options on their own. I mean, is there any support or grants given or anything like that in the government sector for this?
Unfortunately, not in the private sector. We in the private sector have had to find our own funding. We've used major corporations to help us fund some of these operations.
Mm.
We've used a very famous fast food chain in the last 15 years to help us do some of these cases in the private sector. We've had help from insurance companies to help us do some of these cases. And in Sarawak, we go over to Sarawak once a year to conduct free surgery for the kids there. And there, the funding is done from the local people, the local fundraisers there. They raise funds to pay for the treatment. But that's how we've been able to finance some of these cases in the private sector.
Right. Because I'm just thinking it's around 8,000 to 9,000 per surgery. Let's just say the parents can do the early ones and something happens along the way. If it's not the whole way through and you can only do like the early stages,
Like the repair,
like
not
the
the
repair,
refinement.
right.
Yeah.
Can they have some semblance of normalcy, I suppose?
Yes, of course. If surgery is done well and you can get it done, that's fine. But the key is to have continuation of care.
Mm.
You know, it's very difficult for a child to go through this kind of lengthy treatment protocol without a continuation of care. Ideally, you should get one surgeon look after the child from birth up to fully grown. Obviously, that's quite difficult in most in majority of cases.
Mm.
But here in the private sector, we've been able to do that because I've been personally in charge of some of these patients, taking them through from babies onto the fully grown. So we've had a group of kids who've been through the whole process here with me.
Is there, I mean, do your kids, have they got their sort of little support group going? Do they know each other? I mean, you know, does this community have a support group?
Yes. When I first came back from Britain about 30 years ago, I was inundated. I was surprised to see so many kids waiting for their operations. And I was seeing unrepaired lips and palates. Even in our community, you go to market, you find some kids who've had lips and palates done, not repaired.
Mm.
So over 30 years ago, I think we set up the Cleft and Palate Association in Malaysia, the first parent support group. And I'm very pleased to report that the support group is still going very strong and doing well. And it's fully run by parents now, not by professionals anymore.
That's fantastic.
So the Cleft and Palate Association of Malaysia is still going on.
That's fantastic. So Dr. Kim, as an experienced surgeon, why do you think corrective surgery is so important, taking into account the physical side, the mental health side, the self-esteem side, all of it?
I think all of it. I think it's very important that we, as surgeons, help the cleft lip and palate children lead a normal, healthy, well-adjusted life. Because a lot of these kids have the potential to go and fulfill whatever they have to do. I'm very pleased to report that I have had 2 kids now going through the whole process and become doctors themselves.
Wow.
Oh, that's brilliant.
Yeah. I've had just recently another patient has graduated as a lawyer.
Dodgy. I'm just joking.
Yeah.
I come from a family of lawyers. Joking.
They're normal kids with full potential to do whatever they have to do.
Mm.
So, and they're special kids because they need special treatment. That's all. Everything else about them is normal.
Yeah.
So it's very important that the surgery is done and treatment is done to allow them to achieve this.
Mm.
I'm still slightly bummed out about the insurance bit. I still cannot believe that there's no insurance for this.
Yes, this is one of the major exclusion laws by insurance in this country. In other countries, government has legislated that insurance company must pay for congenital abnormalities.
Which
I
makes
think
complete sense.
I just cannot understand why they exclude congenital abnormalities from my insurance.
All right.
We're going to lobby for this, I think, and I think I encourage the support group to lobby our insurance company to make them cover kids with congenital anomalies.
Doctor, if there's sort of one thing that you say to your kids and to your parents that kind of, I don't know what the right word is sort of exactly what they need to hear about this journey that they are about to embark, are already on the journey of, obviously not your patients and stuff. What's the one thing you would say to patients and kids who are facing this?
It's difficult. I mean, it's a complicated thing. I mean, but I want parents to understand the long-term protocol that the kids will have to go through. That's very important.
Mm-hmm.
Understand the treatment protocol for the patient. Understand that the child will have to go through all these procedures, but they need to control and help the children go through this treatment protocol. It is difficult, but it's very, very treatable. Now with availability of treatment in our country, all children with cleft lip and palate should have their treatment. There's no more excuse for not having their kids treated now. And if you can do the operations in the right time, in the right place, then the child will have the chance of fulfilling their full potential. So lots of encouragement, a lot of information and reinforcement really, so that they can get the full treatment that they require.
Awesome. That was wonderful. Thank you so much.